Welcome, everybody. It is Friday, July 19th. This is Peter Antevi and Tanner Smita coming to you with the Florida EMS Webinar. And today we have an amazing treat. I met these two gentlemen um, along the way, probably several years now. We've met really at the Zoll conferences, and I've been enamored by the work that they've done with their data collection, and then not just understanding their data, understanding trends in their data, and then figuring out an implementation to the problem. And that's exactly what you're going to hear about today, where Mike Humphrey and Adam Perrett, they're from Lethbridge, which is in Alberta, a province in Canada. And they are one of the highest performing agencies that I've ever met. When I heard what they were doing, I said, please, this is months ago. I said, can you please come on the webinar? And we have them here today. So without any further ado, Mike and Adam, if you want to make some further introductions, and then we'll go ahead and get started. Can't wait to hear your talk.
Perfect.
Awesome.
Good morning,
Thanks,
everybody. Thanks for joining us today, and thanks, Peter, for inviting us to give this talk. My name is Adam Perrett. I'm the Medical Training Officer for Lethbridge Fire and Emergency Services. And I'll just leave it at that because we do have a bit of an introduction just built into our presentation. We're trying something new with this one, so we're going to try that. Do you want to say something, Mike, or we're good to go?
Oh,
Yeah, Mike, go ahead, Mike.
I was waiting for the intro page.
All right, let's wait for the introduction page then.
I don't want to intro myself twice.
So we'll start right away here then. And what we'll do is we're going to talk about case review and some of the things that we're doing here in Lethbridge. And so what we'll do today is we'll kind of go through our introductions and our backgrounds of what it is, what happened with our service, and how we got to where we are, some of the initial trends, and how that led to a protocol change. And then finally, the newest thing that we're working with is clinical handover with our care center. And so I am Adam Perrett. I'm the Medical Training Officer with Lethbridge Fire Emergency Services. My main role and responsibilities here in Lethbridge are to facilitate all medical training that runs through our department to ensure that our members stay current with their licensing, meeting all those requirements. And then I'm the co-lead with Mike here with our cardiac survivability program.
I am Mike Humphrey. I'm the EMS Operations Officer at Lethbridge Fire and Emergency Services. My primary role here is to identify issues, trends, or concerns within EMS and within our community, and make sure our paramedics have strategies in place to deal with them.
And so just so we get this out of the way right away, we have no conflicts of interest. Everything we're gonna talk about and show you today is our experience with using Zoll X Series Advanced and the integration with Zoll Online. I believe it used to be called Premium Case Review or Case Review Premium in the States. And so this is just kind of what we've done with this and what we looked at. We do know there's many options out there for different monitors, but we just don't have a working knowledge of all those. And then I want to make sure to mention as well that Mike and I are not a research team. And so we're actually a QA/QI program that we've kind of recognized that we found a need for some stuff. So as Dr. Antevi said, we are from Lethbridge, Alberta, Canada, and that's the third largest city in Alberta. And we can see just on the very bottom there where we circled, we're about an hour and 15 minutes north of the Montana border. And so that's kind of where we sit, is right down in the southern part of our province. We are a all-hazard, fully integrated fire service. We've got about 190 frontline members. So 149 of them are advanced care paramedics, 29 are primary care paramedics, and I think that's EMTP advanced and an EMT intermediate for a lot of places, and then 12 medical first responders. Those 12 have all been advanced care or primary care paramedics at some point in time in their career. In 2023, we did just under 24,000 EMS calls and then an additional 3,000 fire calls. And what we've been able to do since January 2022 to December 2023, we've collected 218 adult cardiac arrests, and we have about a 31% ROSC rate. And so what happened for us, or where we kind of all started from, Mike and I we came into our positions relatively at the same time. And we had this great program that we ended up working with. And so on October 14th, 2021, excuse me, that was kind of the first call that Mike and I started to evaluate and say what went well, what didn't go well, and how can we reproduce some of the good things. And so this was a standard response with our service of an ambulance and a fire truck for a 79-year-old female who was witnessed cardiac arrest in a private residence. Our engine was there first, and the nozzle person jumped out of the truck, went running into the house to see if it was a cardiac arrest and to start care if that was the case. The ambulance arrived about 40 seconds later. They were able to get all of the equipment, bring it into the house, and work really as a really good cohesive team. And so what initially happened was the patient was in a PEA rhythm, and so our members started to go down that typical PEA algorithm. They ended up getting a ROSC back and into a sinus rhythm. They then started noticing they were getting longer runs of VTAC with a pulse. They did synchronized cardioversion twice. Patient went back into, and that's, so the top line is the initial rhythm or the ROSC, then the bottom line there is this cardioversion. And then they started to notice that the patient was having longer runs of pulseless VTAC. And so they did CPR again, defibbed, and again got a second ROSC back on this patient. And as they were packaging, we had a really high-performing crew there, and they noticed that the heart rate goes from about 100 beats per minute down to about 45. They started to treat aggressively with norepinephrine infusion and pacing, a little bit of fluid challenge as well, and they were able to get a sustained ROSC all the way to the hospital. And so you see that top line is the defib, the second defib, and then the bottom line is where they started the pacing and got the ROSC back. And so this crew did an amazing job. And so what we looked at is we said, this helped to inform what our high-performance CPR system looked like. And so we said, if these members can do such a good job without any formal training, without any formal kind of program push behind it, we can have all of our members perform at that level. And once we ended up putting on this formal program and we had all of our members operating at this role, we really started to notice this increase in ROSC, and our staff really started to perform at an extremely high level. And so one of the things that we noticed, go ahead, Mike.
Yeah, so one of the initial trends that we noticed was, first off, after this call, we committed to performing 100% cardiac arrest reviews and then feedback to our members, usually within 24 to 48 hours. So we looked at our first 20 ROSCs, and in doing this, we recognized a pattern of hypotension that was present in 12 of those 20 cases. So over the next two slides, we have 11 of those 12 hypotensive cases. And I just want to explain what exactly you're looking at here. So these colored bars you're seeing are the event summaries of individual cardiac arrests, where yellow is a CPR period, purple is a ROSC period, and then there's a rearrest, and yellow is another CPR period. So we noticed that hypotension is a sign that a rearrest is imminent. Go ahead, Adam. Can you jump one back a slide there? So we looked at the duration of that purple section, that ROSC, and we basically just measured it. And what we noticed is that the ROSC period of a hypotensive patient would last anywhere, usually between 2 and 9 minutes. And interestingly, all the PCRs read the same. We did CPR, we got ROSC, we started packaging the patient up, moved him to the ambulance, started CPR in the ambulance. Go to the next slide. What we noticed is that these 4 patients actually were hypotensive, but they had sustained ROSC because, and the only thing that was different on these cases is that they received early vasopressors. So we had a couple high flyers that were delivering early vasopressors right away. And I think you can see that maybe there's a difference here in the care of these patients. So what was, go ahead, Adam. And so this was our past protocol. We looked at our protocol that we had, and it's a little bit confusing, but all you have to know on the left side, do we get a ROSC? Yes. Is the patient hypotensive? Yes. Jump over to the right slide. And what you see is basically the protocol is normal saline 500 ml bolus to a max of 2 liters, and then online medical consultation for norepinephrine infusion. What we found is that process takes much longer than 10 minutes. And so our patients, the protocol just didn't meet the patient pathology needs. So we changed our protocol. Go ahead. We brought this trend to our medical director, Dr. Orr, and he really empowered us to craft a protocol that met the patient pathology. And so we needed to create a protocol that was implementable within 60 seconds of the ROSC. So basically, it's a kitchen sink protocol. So we're going to give, if the patient's hypotensive below 90 systolic, we're going to do concurrent fluid, vasopressors, and pacing if applicable. So Our protocol is 20 mics of push-dose epi, Q2 minutes until we get a BP above 90, or we start a norepinephrine infusion. And this is what our event summaries look like now. So you can see these are all hypotensive patients, and you can see a much longer sustained ROSC. What you'll notice in some of these slides is blue is mechanical CPR. That's the auto pulse. So we kind of implemented that about the same time. But it's not push dose magic. You do get some rearrests. But what we can see is that our rearrest rate and our prolonged ROSC is much longer. So our rearrest rate went from about 50%, and the prevalence of hypotension was 50%. So you can see if the patient was hypotensive, they always rearrested. And we had an arrival to ED with a pulse of 50%. After implementation, our rearrest rate dropped to about 23%. And then our arrival to ED with pulses was just under 90%. It was it's 87.5% now. So this is a draft of what the protocol in our province is going to look like in 2025. And so what you can see here is you immediately obtain a set of vitals, Q1 minute on blood pressures, and then you can see, is the patient hypotensive? Yes. Normal saline bolus and concurrent push-dose epinephrine as a bridging mechanism to get to norepinephrine. So this will be going live in the province. This happens to be our pediatric protocol, but our adult protocol will be looking very similar to this. And so, it's not only important what you do, but it's just as important how you do it. And so this is an operational performance. So what you're seeing here is called vital signs trends, and it's a hypotensive ROSC patient. So the vertical axis is the vital sign value. The horizontal axis is time. And so the first third of that call before the vertical blue line is CPR artifact. And then you can see right where it's annotated ROSC. That's where ROSC occurs. And then after ROSC, you're going to see a dark blue line, and that's the heart rate. And then the three lines below that are systolic blood pressure, mean arterial pressure, and diastolic pressure. And what you'll notice here is that within 5 seconds of the ROSC, that blood pressure is starting. So they were prepared for the ROSC. The blood pressure comes back within 30 seconds. And within that first 60 seconds of that ROSC, they noticed that the patient was hypotensive, about 80 systolic, and they immediately deliver push-dose epinephrine. They gave 4 push-dose epinephrines, and that's kind of what we call the epi wave. So you'll see big swings in blood pressure up and down. And then kind of right after 1319 is when they transition to a norepinephrine infusion. And what's interesting about this is that as the patient becomes normotensive, heart rate actually comes down, and this patient is much more hemodynamically stable with that norepinephrine infusion.
And so one of the things that we noticed is that, or that we started to recognize after that, is that our rearrest rate goes down, our arrival to emergency department goes up, and all of a sudden we've taken these critically sick patients from their living room, and we're now dropping them on the doorstep of an emergency room. And this was happening with more and more frequency. And the truth was, what was happening at that hospital was just not equipped to handle these increased sick patients. And so we were able to capture these 4 patients here. And all of these 4 patients all had a sustained ROSC with our crews. They were critically sick, but they were stable. And during clinical handover at the hospital, they rearrested. And so whatever we were doing wasn't working. And so when we have a rearrest in the hospital, what we're doing is we are breaking the chain of survival. And we're all very familiar with what the chain of survival is. We have very little control over everything we can do prior to EMS and hospital team working together, right? So telephone CPR is really important, but and we can have all the protocols in place we want, but we really have a limited option of what we can do to control that. Bystander CPR, we have a public education program. But again, we have very limited control of somebody performing CPR, and public access defibrillation, the exact same thing. They are available, they're there for use, but if somebody chooses not to use it or doesn't know how to use it, we have very little access to that or very little control over that. And so what we're going to do is we'll look at a couple of these case studies as to what went wrong in the clinical handover and how we were able to fix this. And so this is a patient that you can see the CPR is going along. You can see all of the epinephrine given, and that big blue line there again is where we sustained ROSC. And you can see that they are critically sick. Blood pressures are quite low, and it's a stark contrast to the one that Mike just showed you, where this one looks like there was only 4 blood pressures taken. That's not the case. So they were doing auscultated blood pressures. These are just the 4 NIBPs that they were able to get. And one of the things that we protocolized here in Lethbridge was that people love to use NIBP even on critically sick patients. It's what we kind of revert back to because that's what we do all the time. And so we've told our staff, if you're getting what's called an NIBP timeout, so you hit the button and it just takes too long and it comes back and it says timed out, or it is taking an extremely long period of time to come back, we are to count that patient as a critically hypotensive patient and treat them as such. And so they really did do quite a few more blood pressures than what we get here. And you can see that's that last line there that says clinical handover. So our members were using push-dose epi in this case, sustaining this patient to get there, a very, very sick patient. But what happened was they got close to the hospital and they transitioned their mindset from patient care to transfer of care. And so they started to load the patient up. They started to discontinue what they were doing. And it was by no means their fault. What we know is that when you get task orientated, you all of a sudden can't concentrate on more than one thing at a time. And so they were concentrating on getting this patient out of their ambulance because of how sick they were and getting them into the emergency department to have more sustained care. When that happened, you can see at the very end there a rapid drop in pulse rate, and they went right into cardiac arrest, and this patient was not able to come back. So the other case study we're going to look at is, if anyone's not familiar, this is our Accuvent data. So Accuvent is a product that we use with the Zol X Series Advanced, and this will give you real-time BVM feedback for tidal volume, respiration rate, and end tidal CO2, and it puts it on the screen for you. It is an absolutely fantastic tool. And you can see the first kind of third of that call. We're pretty good at keeping the tidal volume between about 400, 450 mils of air per breath. The rate is really good, right at about that 8 to 10 breaths per minute. And then something happens at 2010. And so you can probably guess that's where clinical handover started to happen. And so we all of a sudden start moving into the hospital. Somebody who's not familiar with the equipment, who is starting to do multiple things at once, takes over the airway, and you can see what happens, right? The respiration rates at some point go almost up to 40 breaths per minute. We're looking at tidal volume of close to 950, sometimes 1,000 mils of air per breath. And we know what happens when that goes, right? That we're hyperinflating these patients. And this is one of the H bombs. Right? And so this is the same patient. And so this patient was being paced and norepi infusion. I think we kind of told a story about that earlier today. And what you can see is if you look at the time there, and we look at 2014 on that top line. So 2014-50 is when the pacer gets turned off and the norepinephrine infusion stops. And this is during the handover in the trauma bay. And if we look at that bottom line, 2016-08, and that's CPR starting again. And so we recognized this and we said, okay, there is a problem here. We're coming in and we're having these critically sick patients and we're turning everything off and stopping everything. It takes too long for the hospital staff to wrap their brain around what was going on in that patient pathology. And so again, we went to the hospital and we went to build a team with them. There was no one that was to blame in these situations. It was just a system problem. And so we wanted to fix the system. And so we were quite lucky. We have a very great clinical educator at our hospital and that was willing to work with us and was really impressed by what it was that they were able to see. And so this is the program we came up with.
Yeah, so we ran a few sims at the hospital with the staff and really tried to come up with defined roles of how we're going to do clinical handover. So I'm not going to read all of these, but the ER team, that's just a list of a cascade of events that they're going to do when we're bringing in a ROSC patient. And so you can see one of them is, hey, get the norepi out and ready to go. One thing that we're going to make sure that we do is all of our info patches are going to include use of vasopressors. The next thing is that when we arrive to the hospital, what we're going to do is we're going to keep that patient in care of our members that have the sustained ROSC while we give verbal handover to the ER staff so that they're not task oriented and they can wrap their brain around what or wrap their brain around the present pathology. And then right before clinical handover, after we've told the story, I guess I'll just highlight here is that we're going to take that last blood pressure. We're going to adjust our vasopressor if we need to. We're going to do a deadly cardiac rhythm check, deliver electrical therapy. We're also then going to brief the RT on our vent strategy and have them get feel with the AccuVent before we move the patient over. So after all that, we're able to move the patient over, and then we'll be able to switch over to all their equipment, and then final questions can be asked and answered. And so what does this look like in the data? So this was actually a successful handover after we did this. And so, Adam, can you just use your mouse and right over arrival to CRH? So right there is when we got to the hospital. And what you'll notice is that by the time from the time we got to the hospital until we had clinical handover, our members took 6 more blood pressures. And that represents a methodical approach to handover that we're telling the story, and this patient is completely monitored, and if there's an intervention to do, that they get a timely intervention. And this was one that we just had, I don't know, a couple of weeks ago. So same thing, you can see this is a ROSC patient, arrival to hospital, and then there's each one of those little points. I think that's 5 more blood pressures. And so this is how we do clinical handover, and we believe that we've seen a dramatic increase in patient safety.
Yeah. And we've got great buy-in from the hospital on this because we understand that what a rearrest means to our hospital is that that's going to pull in another 3 to 4 nursing staff. That demoralizes your team. It stops current treatment from happening to all the other patients that are currently in emerge, because now they're getting delayed with a short staff. We're missing break times, you're missing lunch time. So all these things now we get to be caught up. And we have, by the way, we just had 50 to 60 more patients walk through the door also looking for care. And so we know that when we have these derailments, it can take several hours for you to actually catch back up to where you were previous to the cardiac arrest. And if you have multiple these events happening multiple times in a day, it's sometimes 24 hours or more before your emergency department is able to catch back up to where they were right before. And so just so we can quickly summarize for you, so what we're doing here in Lethbridge, using case review, and some of the things we've been able to do is we use case review because we can evaluate our crew's performance. The vital trends section of that allows us to look right into their clinical mindset as it was happening. We've been able to appraise our current protocols. We develop new protocols. We can target treatment, what we need for our critical patients. And one of the big things is just improving the service relationships with our service partners. And that's what we've got for you guys.
We'd be happy to answer any questions you may have.
Wow, I'm just giddy here. This is what a great presentation. Let me just make sure I get to the Mike. Do I have you off? Yes, I do. Okay. Let me bring in Tanner. Tanner, you've done work on this. I know you've connected with Mike and Adam in the past. Take it away, my friend.
Sure. Yeah. And first, I just want to say that I think the world needs more EMS clinicians, pre-hospital clinicians like the two of you that, use your data to drive protocols that get our patients what they need, drive systems of care. I think you've done a phenomenal job here. Really wonderful presentation. And so, I think a lot of what you're saying underscores a lot of what we already know about rearrest, right? So to kind of recap, it's very common. We presented data before on this webinar that suggests in the United States, nationwide, 1 in 3 patients with ROSC is going to experience this phenomenon. Prior data suggests that it's associated with more than 80% decrease in survival to discharge, similar decreases in neurologically intact survival. And so this is a problem that we really have to face if we want to, drive forward the standard of care for out-of-hospital cardiac arrest patients. And so I'm really impressed by your data and your services experience. So I have one question for you guys. So there was a paper published from the LA County group where they implemented a bundle of post-resuscitation care that didn't include hemodynamic management, push-dose epinephrine. And when they did like a before and after comparison, they looked at a couple thousand patients, and they found basically no difference in rearrest, survival, neurologically intact survival. But I think one of the things that they suggested might be the reason behind that is they saw kind of a signal that might indicate kind of limited uptake or kind of protocol compliance by providers. And so while they did see increases in normal saline boluses, it went from like 10% to 30%. They saw increases in push dose epi administration from like 3% to 12%. Still, an absolute, it was a small number of patients that received these interventions overall. So I'm wondering if you ran into any challenges with kind of providers out in the field, kind of embracing these changes and, kind of resuscitating these patients on scene, or I guess any measures that you've employed to make sure that compliance with these protocols will be what you want them to be.
Yeah, Tanner, we do 100% cardiac. We do 100% review on this, and then we've QA/QI the program. So when we first started, we didn't see a massive decrease in rearrest. We had to really QA/QI it, and because our members want to get off scene and want to go. And so it was a cultural shift where we had to say, no, you have to stay. You can't go anywhere if these patients are hypotensive. And so really, it took us a good year to really QA/QI this, so that we had immediate buy-in from our members. It's just that there were some things that they just didn't know how to use the tool, right? And so this isn't really taught widespread in schools, and so it did take a while to actually QA/QI this. So, but you know what? We have seen a number of patients that we believe just would have died in the field and not got to the hospital. Also, there's been a massive amount of organ donation that these patients just would have died in the field. We had a recent case where we had a young lady who had an opiate overdose. She had an anoxic brain injury. She was critically hypotensive, and we're virtually certain she would have died in the field. But she was able to donate her heart to a needing and thankful recipient. And so how do you put the data doesn't capture some of that stuff too, right?
Right.
Yeah, and Tanner, I'll add in that what we did when we started our program is we actually approached our staff and said, hey, this is what we'd like to do. Who's interested in helping out? And so we had people join us. And so it really was Mike and I not telling people what to do, but just looking at the data and saying, hey, here's what we're noticing. What do you guys want to do about it? And so they became a staff-driven event. And once it becomes a staff-driven event, we just kind of hold the reins and guide them where we need them to go. And they're doing all the work, and they're accepting all the changes. And so when we started to do a review, so that first call that I showed you from October 14th, that crew was with no training program, had about an 87% chest compression fraction, and which is a high-performing crew. And so once we started to give data feedback to folks, that number started to creep up on its own without us doing any sort of training whatsoever. And then we said, okay, without a formal training program, without any sort of formal education, what is it our crews are doing? Well, let's push them now. And so now our standard is 95% chest compression fraction for all cardiac arrest, regardless of how long the duration of the work. And so our members
you just do the alarm. I got to bring this in.
Hey, Charlie, Stan, you're live. Let me meet him.
And so our members have really been able to grasp onto this and really push it. And so they consistently hit that number. And it turns into a really friendly rivalry. So we do release the numbers based off platoon as well. And so guys are like, you guys are at 93.5. Well, we're at 94.2. We're so much better than you. And it's like, I can't let that crew beat me. And so there's this really fun kind of friendly rivalry that we do. And then we also ensure we train on it quarterly. And so we do a formal CPR course every year for certification. And then kind of at the 6-month mark, we have them run a scenario, upload the data, take a look at it again. And then kind of in the counter quarters of that, right? It's more of a roundtable discussion to be like, hey, remember roles, responsibilities. What is it we're doing? What role does this person have? If you're rescuer number 4, what is your job that day? And so they know that when they walk into a code, there doesn't need to be a conversation. At no point in time is it ever, hey, what do you guys need? Because they walk in knowing what their role is, predetermined. And we kind of stole that from the fire side of our business, right? If we go to a structure fire, we know exactly what it is we're going to do when we get out of the truck, because that's our role that day. And so we took that and put it into our EMS side, and our membership is just eating it up.
Adam and Mike, we have some great questions coming in. Let me see if Dr. Lee, are you available to unmute, or you want me to just say it, verbalize it?
Well, it was a simple question. I just wonder if you know how many of the patients that you use vasopressors on and had return of ROSC survived a hospital discharge relative to what you normally would expect.
I don't think we have good data on that specifically. But yeah, I would say that people that are hypotensive post-ROSC are not going to go, a lot of them are not going to go skipping out of the hospital, right? So it's a sign that they're critically ill, and they're going to have worse outcomes than somebody that's normotensive or hypertensive post-ROSC. So I'm not 100% sure they're
well, I guess my question is driven by I think there has been some discussion in the past that vasopressors may be detrimental to hospital discharge. And even though they give us ROSC, they may not be useful in the long term. That's where it's coming from.
Right.
Yeah.
Right. So I think.
Yeah.
Oh, go ahead. No, go ahead.
Just the cost of a rearrest to the system is significant, and I think it's just a lot more clinically. I think it's clinically better to avoid the rearrest. Because you're doing CPR in the back of the ambulance, you're doing CPR in the hospital, and if you just give them a little bit of vasopressor and then they can prognosticate at their leisure up in the ICU, I think that's a good plan.
The other part of that is that we've had an increase in organ donation, which unfortunately, so we use CanRock, which is very similar to your CARES data, and so we are waiting for survival to discharge information to come back from that. It just takes, as you guys know, takes some time for that to get processed through. And so the one thing that it doesn't actually have is that organ donation and all the lives that you can affect with that after that fact.
Yeah. The comment I wanted to make to Wayne's point is that, many of us now in CARES, we actually look at several numbers, right? And, a lot of people focus on ROSC. And then when we start to ask, well, why aren't we focusing on neurointact survival? The comment you typically hear is, well, because there's so many factors that could happen at the hospital side that could screw things up, that just because we're not getting the neurointact survival that other people are seeing, that doesn't mean the EMS section is not doing a good job. But to the point of this amazing talk today is that we've all seen exactly what you're talking about over and over and over again. We've seen it in front of our eyes. I've seen it at one of our local hospitals where we come in, guy has ROSC, no one's even there to accept the patient, and then by the time they do, the guy is back and he's rearrested, and those patients have a bad outcome. But to Wayne's point, Dr. Lee's point, if you guys can show that, hey, this avoidance of hypotension, avoidance of rearrest leads to neurointact survivors, then that's the huge win, number one. And then secondly, I would bet that not many people are as savvy as you are with whatever monitor they have. Okay. I mean, my agencies have both Zoll and we also have LifePak, but it took us time to get to the point where we are really savvy with looking at the data, looking at these timelines. And if we had a poll here today, I would wonder how many people are actually looking at their data to understand why Mr. Jones rearrested and why they got ROSC, 37% of the time, but their neurointact survival is, 6%, right? It's not that good. And so what would you recommend to people? And I know you guys use Zoll. How did you become so good at doing this? Did you have to learn it from somebody? How would you recommend people who are not doing what you're doing today actually get this type of data visualization on every single patient?
Yeah, Peter, I think where we started, and I think what really drove this is that when you give timely feedback, not only do your members learn, but the people giving the feedback start learning too. And then you can't help but start noticing trends. And then it's really about, walking and chew gum at the same time, where you're taking lessons learned that, and you're always sending the same feedback. Oh, hey, maybe we need to do some training on that, or we need to look at that a little bit more. So I think that's where you start, is that you have to have 100% review, and then you'll start learning because you're giving the same feedback, and you'll see those trends within your agency.
Great. And then I'm going to bring in Dr. Charlie Ingram. So for those of you who don't know, Dr. Ingram is coming into Florida. The new EMS medical director just moved here into Boca. He's going to be joining my team here to help me out. So Charlie, welcome. And you made some comments in the chat. If you could tell everyone where you're coming from, and I would love everyone to welcome you here into the state.
Awesome. Thanks, Peter. Yeah, so as anybody possibly saw in my background of my boxes, I have officially joined the Florida homeowners now, and have not unpacked. But yeah, I am an EMS physician as well. I did the kind of EM residency at Cooper in New Jersey, and then EMS fellowship at Yale, was faculty at Yale for a couple of years before coming down here. And I'm going to work with Peter and Terry Cohn, kind of in the Broward, Palm Beach region down here. So I've
Awesome.
met a handful of people on, but it's nice to meet everybody else. So looking forward to it.
What's your comment on the? I see you have some comments here. What are your thoughts on the presentation today?
Yeah, it was good. I mean, I think that there's just a huge kind of like that clinical transition period is massive, right? And I think you see it in two different places. You see it, and what we found kind of where I was previously, we found it in extrication times, and like where we're extricating, like especially your respiratory patients, your STEMI patients. Like if you stabilize them, you can extricate them. If you extricate them to stabilize them, they will arrest in the extrication. And it's the exact same thing. You're just extricating them from an ambulance now into the emergency department. Everything is changed, right? So like all of the roles that you had set up are great when everyone is seated in their positions in the ambulance, and now everyone's jogging down the hallway trying to get to the room. We see patients rearrest there all the time. And I personally do the kind of a similar thing where like I had a patient that was pacing, and I learned it the hard way because one of my techs cut through the pacing wires. And that was the only thing keeping that 3rd-degree heart block alive. The next one I had, I put a transvenous pacer in while we were still on the EMS monitor, right? So like a drastic difference there. I think like that's kind of my approach to it, clinically at least. And then doing that exact same thing, kind of having everybody set, figure out what you need to figure out, and then move your patients, then hand off your patients, et cetera. Taking that team lead to kind of reset the whole picture first.
Yeah, it's super simple, but it's not, sometimes it's not easy, right? And so you just have to really slow down and go through the process.
And so a lot of
so Adam,
yeah,
I was going to ask you, Adam, how do we make this paradigm shift where this EMS transition into the hospital, which is maybe one of the most underlooked aspect of care, how do we highlight that and actually make a difference in that?
So it worked out for us. That Mike was there talking with the clinical educator, and the clinical educator's name's Randy. So Mike's there talking to Randy, and it happens to be that one of our mutual aid services was bringing in a ROSC patient using push-dose epi. And so I'll let Mike tell the story because he's really good at it. But basically, he looked at Randy and said, "Hey, what are you doing right now? Well, let's go watch this and don't say anything, don't do anything." And then go ahead, Mike.
So we just basically went into the trauma bay and just watched. And this is after we've kind of shown her the data. And yeah, they rolled into the room, they ripped everything off, they moved the patient over, and then they started doing all this stuff. And I'm looking over at Randy, and she's looking at her watch, and she's now tapping her foot. And then she goes over, she's like, "Hey, take a blood pressure." And then they take it. So it was about 4 minutes between blood pressures, and then it's like 70 on 40. And then there's a big panic to get it going. And so really all we did is you just have to understand and really just giving the clinicians the understanding that when you're bringing a patient in with life-sustaining therapy, like pacing, vasopressors, there can't be a gap in that treatment. And so there needs to be a methodical handover. And once that message is there, things get a lot better.
Yeah. And so one of the things that we know is hospitals are really good at giving data about how many patients they see a year, how long the average wait time is in the hospital, kind of what their staffing numbers are. They do not track staff performance. They do not track team performance. And so you can say, "Hey, how many patients did you have today?" And that nurse can tell you exactly how many patients they had throughout their shift. But if you say, "Hey, you did CPR today, what was your chest compression fraction?" And they'll go, "What's chest compression fraction?" We don't know. Right? How many med errors did you make today? Well, we don't know. We don't track that. Right? But they will be able to tell you that the average person is waiting 77 minutes in the emergency department. It's just so it really is a mindset switch to say, "Hey, let's work as a team. This is what we've noticed from our members, and now we bring that over to the hospital." And actually, the very first, so we presented the clinical handover information to nursing staff because this was a nurse and EMS driven event. This was not a physician driven event. And so we presented it to the nursing staff on their training days in February. And then a week or so after we presented, this was the first clinical handover that we had for a ROSC patient. And one of the doctors came in and started going just like they used to in the old days. And they started saying things and talking over top of people. And one of the nurses looked at him and went, "Hey, we don't do that anymore. Just stand over there." And then the doctor was like, "Oh," and stood in the corner and had to wait for handover. And then the nurse looked and said, "Okay, now you can say what you wanted to say." And it really is quite a change.
Yeah.
But it is
Wow.
it's just getting buy-in, right? It's working and building those partnerships. And I think Peter, your service does it great. We've seen the video where you do the cardiac arrest to say here's how our members work, and then you transition over. And we've had our staff members ask us if we can do the same thing. So that's kind of one of our next steps.
Yeah.
The hospital wants this to happen, and so we're working closely with them. And it's opening those communication lines and creating that bond.
Yeah, the other thing we're trying to do is convince them to leave our monitor on for at least 10 minutes. I'm calling it the warm handoff, so that we can actually see the data. The slide that I love that you just had was when you transition care, and all of a sudden the volumes on the ventilation was going to 1,000, and all the other vital signs went haywire. I wish we could take a snapshot of that to show the world that it does matter how fast you're ventilating. It does matter the volume that you're ventilating at. Not many people today know the ventilation volumes. I know there's a couple of products on the market. I would love to hear more about at some point in the future that Zoll device that you're using, because I don't think people really recognize that it could be these little nuances. The devil's in the details when it comes to cardiac arrest, and you showed it very clearly on that slide there. That as soon as you handed over care, within 2 minutes, the patient rearrested, and it probably had a big impact that they were creating a large amount of positive pressure in the chest because of the rate and the volume that they were pouring into this guy's chest, and just diminishing cardiac output, cerebral perfusion, etc. So, how about we do this? Let's go to Dr. Lee, and then I'll let Adam and Mike take us away. So, Dr. Lee, go make your comment.
Oh, I really was just doing it in the comments section, but I guess, again, I appreciate your comment that, a lot happens between the ER and potential discharge in the hospital that might account for the lack of neural intact survival. However, with that said, I think there is a pending question, of what role vasopressors play in that. And to the extent that it's my understanding that some EMS systems have removed epinephrine from the truck, and so I just that comment. But I do think that regardless of what the reason is, I think it would be useful as you guys continue on. And by the way, I compliment what you've done. It's very sophisticated. I appreciate it very much. At the same time, it would be nice if you can track neural intact survival of those same cases.
Yeah, Dr. So we are working up to that point, right? We're just waiting for our data to come back. Just so it's a few years behind. So it takes a few years for that information to run through to our CanROC and then get back to us. It's not as sophisticated as CARES is. It's a few years behind that. And so it's funny. One of the things that you say that EMS systems taking it off completely. The big thing they're looking at, kind of nationally or internationally, I guess, is dosing of epinephrine in cardiac arrest and dosing of how to do it. Right. So it's not so much that it's necessarily not working, and we know by the Paramedic 2 study that it gets ROSC back, but it doesn't increase neurologically intact survivors. And so when we look at that, though, and Dr. Antevi, you've talked about this before as well, is when you look at how long it takes for that epi to get on board, and how the total volume of epinephrine we're getting. And so what the newest thing with EMS service is actually restricting that down from 1 every 3 minutes till you stop doing it, which, in our system, that would be anywhere from about 9 to 10 milligrams of epinephrine, which we know has negative neurological outcomes. And they're starting to look at kind of 2 milligrams, 2.5 milligrams maximum for the cardiac arrest. And so we are starting to see that stuff come through. And that's kind of our next things that we're looking at. And so the other part about this that I'll say is that the ultimate goal is a neurologically intact survivor. Absolutely. But you can still have negative patient outcomes and successful calls. And so when we are able to get the organ donation, when we are able to look at what our memberships are doing and we give them the feedback, one of the things we didn't touch on this slideshow is the positive effect on mental health that our membership are getting. And so we go into cardiac arrest, we work our butts off, and we just don't ever know, right? Did we do a good job? Did we not do a good job? How do we know this? And so the system that we have here, giving the feedback, giving the data to our membership, it allows them to know that no matter what you did, like you or no matter what the patient outcome is, pardon me, is that you worked the very best you possibly could, and you did everything you could to keep that patient alive, or to give that patient the best chance of survival they could. And so they're now able to kind of close that call on. They're able to move past, as opposed to doing what we used to do in the past, which is, you know, the 20-year medic had a backpack full of patients that they had no idea about what or how well they performed. And so, again, neurologically intact survivability, absolutely number one goal that we can have. But secondary to that is there are still successes in negative patient outcomes.
Just to be clear, I'm not against return of ROSC or epi.
Yeah,
but actually, Wayne, I do want to clarify. We did remove epi from our shock rhythm protocol. But like we had a case yesterday. Guy got double sequential 4 times. He got esmolol. Actually, knock on wood, he got ROSC and is doing okay. Last we heard, but he ended up needing epi from our folks after ROSC. So I think the post-ROSC, requirement of epi, nor-epi, etc. I think is important. Lou Steinberg asked the question if you're seeing a difference between administering push dose epi to shockable versus those of non-shockable origins. That's another good question that I'm sure that you can look in the data, but we do have to stop. But I do see that Ian Blanchard, he says that Mike and Adam are being polite, and he is the PI of Canrock in Alberta. So Ian, welcome, and you want to make a couple comments while you're here? We're so happy to have you.
Yeah, perfect. Thanks so much. And Mike and Adam were being super polite there. So they've been very patient. We've been trying to get their outcome information linked here for a while. It shouldn't be that hard because we're all part of the healthcare system here. And I just want to say it's been so good working with Mike and Adam. It's kind of like having a beta test shop, right? Because we've got about 5,600 paramedics, and it's really hard to make change. Like, we're a big ship. And so Mike and Adam are leading the way in the province. So we basically follow them about a year or two later. So that post-ROSC epi program, that'll unroll province-wide here in April of 2025. We are just undergoing the training right now, so thousands of paramedics are being trained on it. But that all started with Mike and Adam. So it really shows that when you take a look at the evidence and the science, and you just really reduce it down to what steps can a paramedic make and when, and then practice, we can make these changes. So it's been great. So I appreciate being here, and Dr. Antevi, great to see you again.
You too. Thank you so much. All right. Well, we do have to close it down. So I want to give Adam and Mike the final word. So you have lots of, I have never gotten so many Twitter, LinkedIn, people are still texting me now. Do you have the link for the video? I'm like, I'm not even done yet here. So if you wouldn't mind, giving us your final words, inspire the folks who are on this call to do what you're doing. I see, Adam, you're putting your email in. Mike, if you could put your email in. But Mike, we'll start with you. Adam will end with you. So go ahead.
Yeah, I think when you bring data and trends to caring, compassionate medical directors and systems, change can happen. And but that's the key, is that you have to bring data when you're coming to the party, or else people won't listen to you. And that would be my 2 cents there is look at your data. It's really analytics. It's like, all the sports teams are doing analytics to get better. They're watching their game tape and they're looking at their stats. And I think EMS, we need to be doing that same thing.
Amen. Thanks, Mike.
And
Adam, sorry.
That's okay. I'll say that no matter what system you're using, no matter what equipment you're using. So if you're physio, if you're Philips, if you're Zoll, if you're something else that's out there, it doesn't matter what system you're using. It's how the feedback you're giving, or what the feedback you're giving to your members are. And that everybody comes to EMS and fire, and everybody comes to work and they want to do the very best job they can. And so when you have these monitors that are absolutely amazing, they're able to collect all this data, and you choose not to look at it, or you don't think you need to look at it, and then you try to run a QA/QI program, it's essentially like swinging a baseball bat in the dark. You're hoping that you're going to hit on something, and chances are you never will. You'll put a lot of holes in the wall. You'll change a lot of systems that people will be confused on, but you'll never actually be able to connect with anything of significance. And so no matter what system you're on, no matter what you're doing, look at the data, give the feedback to your members, because your members want to do the best job they possibly can. When you start doing that, you will notice a drastic increase in performance right off the hop.
Yeah, very, very well said. And then I'm gonna give Tanner, my partner in crime here, last words as a research brain, as the future of our profession. Tanner, give us some final words.
Yeah, I think as far as future research direction in preventing rearrest, I think we certainly need prospective study of the deployment of this kind of protocol. And Mike and Adam, I'm sure we would love to see your data as you get some of these neurologic outcomes, as more and more patients are being treated according to your protocol. I think we'd all be very interested to see if you continue to see decreased rearrest rates and improved outcomes long term. But as a field in general, beyond just single center studies, I think that is something that we need to prioritize, within our own systems, setting up maybe even prospective kind of multi-center work, evaluating the role of vasopressors and the prevention of rearrest.
And that sure is a big question. So thank you all so much. So for myself, for Tanner Smeda, for our friends to the north of us, Mike and Adam, you guys are our heroes, really. And thanks for putting your emails in. I'm sure you'll get a lot of reach out. We'll put this video up on YouTube as well. I did put the link for Dr. Pepe's webinar up. It's a little higher now. If people want to click over to that, just go ahead and do that. I'll try to find the link one more time and put it in again. But thank you all, everybody, and have a great weekend and stay safe.
Thank you.
Thank you.